From the American Academy of Pediatrics.
Kids across the country are officially back to school, and that means they're back to germs.
Let's talk about the 2024 viral landscape, starting with RSV, flu, and COVID-19.
Certainly, there are plenty of other viruses out there. I think there's going to be a focus, of course, on these three. One, because they are among the leading causes of hospitalization in both children and adults. But two, they are all potentially preventable now with immunization.
Plus, a recent clinical report offers detailed recommendations for managing sickle cell disease in general practice.
With the hematologist or the specialist team, make a plan who's going to do what. Who's going to provide the penicillin prescription if that's appropriate up till age 5? Who's going to give the vaccines? Ideally, that's done in the pediatrician's office.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Pargabalinki. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians, for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about the viral season ahead of us and how we can counsel families.
David, I'm so glad I was able to record today. I feel this tickle in my throat.
Ooh, it is the fall. Kids are back at school and viruses are back in action. So I'm hoping your tickle doesn't get, more sneezy.
Ever since 2020, viral season has been hard to predict. We need someone who can read the tea leaves, or rather the petri dishes, to tell us what to expect and how to vaccinate.
Well, every fall on Pediatrics on Call, there is one infectious disease expert who helps us read the viral capsid, or crystal ball, Dr. Sean O'Leary.
Dr. Sean O'Leary is a professor of pediatrics at Children's Hospital Colorado. He's also chair of the AAP Committee on Infectious Disease. Sean, welcome back to the show.
Happy to be here.
We have to start with a survey of the viral landscape, Sean. Pediatricians expect to see RSV, flu, and now COVID. But are those the viruses you anticipate are going to take center stage this viral season?
Yeah, good question. Certainly, there are plenty of other viruses out there. I think there's going to be a focus, of course, on these three. One, because they are among the leading causes of hospitalization in both children and adults. But two, they are all potentially preventable now with immunization. And at least for two of them, they're potentially treatable, particularly for high-risk kids.
When we last had you on, it was to talk about nirsevimab. Did I pronounce that right this year?
You got it.
Nice. How do you think this immunization will influence RSV transmission and hospitalization?
Yeah, that's a great question. So last season, we had some issues with the rollout of nirsevimab. As I'm sure you both remember, there was a big supply issue. And there is also a timing issue in terms of when it got officially recommended by FDA and ACIP and AAP. That just was somewhat inevitable in terms of when the studies were done and the timing and all of that. But then the supply issue was kind of a surprise. And so what we saw was there actually was a lot of demand for the product, and we saw really good uptake. The problem was, I think it was a little late. So there have now been a couple of studies published showing that actually it worked as well as we expected in terms of prevention of hospitalization when they looked at kids who had gotten it kind of early in the season. The problem was a lot of kids got it after the season was really already in full swing. So I don't think we saw the population level effect we were hoping for last season. I am quite optimistic, though, that we're going to see that this year. Certainly there may be, it won't necessarily go smoothly all over the country. It always takes at least a few years for any new vaccine product to get, sort of fully implemented. And so we're only in the second year of the rollout of this particular product. And there's always bumps in the road in terms of getting it ramped up to where we want to see it. That said, what we are told is that the product will be available in September initially, and then it will be broadly available by October so that pretty much anybody who orders it will be able to get it and immunize all the eligible kids. And we can talk more about that. So all of that is to say, I expect if this rollout goes as we anticipate it will, we should be getting these immunizations into kids before RSV season hits in order to prevent a lot of these hospitalizations. And by the way, I use the word vaccine. Technically, by strict definitions, nirsevimab would be considered a passive immunization. So it is an immunization, but it's not technically a vaccine. Now, it is covered in the Vaccines for Children program. So you'll probably be hearing more and more people use the term vaccine, although technically it's not.
And you mentioned eligibility. Is it still going to be for infants up to 8 months of age?
Yeah, so recommendations have not changed. They are the same. So it's all infants up to 8 months of age, and then high-risk infants from 8 months through 19 months. And those high-risk infants are essentially identical to the infants that were recommended to receive palivizumab or Synagis, with the addition of American Indian and Alaska Natives to that group.
And you are an expert communicator about vaccination. Do you have any tips about how pediatricians can message to pregnant women about getting vaccinated for things like RSV and even pertussis?
Yeah, it's, communication around vaccines is challenging, or certainly can be challenging depending on the circumstances. For this, I think one of the things we've seen with both nirsevimab as well as the maternal RSV vaccine that's now available is demand, I think, was higher than anticipated. I think the big message here for pregnant people and parents of young infants is that, RSV is the leading cause of hospitalization in kids, period. And now we have not just one, but two excellent products that have been shown to be very safe and very effective at preventing those hospitalizations. So frankly, I wasn't surprised last year when we saw all that demand, because parents really, at the end of the day, just want to do what's best for their kids.
And can we get into the COVID vaccine? We are already seeing a new wave of COVID infections in our hospital. What changes should pediatricians be aware of this year?
Well, really, there's no change to the recommendations. Now, the vaccine is different, similar to what we see with flu every year, where we try to match the circulating strains. And it looks like that this year's COVID vaccine should be a good match. But the recommendation remains all kids 6 months and older should be vaccinated against COVID-19. One thing to note is that the vaccines that we had been using up until a few weeks ago are no longer authorized. So the vaccine that is now authorized is the one against the new strain. And so those should be available very soon, if not already.
And Sean, do we still need to be worried about COVID as an infection in children? Is it still a potentially highly virulent issue?
Yeah, David, that's a really good question. And I get that a fair bit. I will say I'm on the COVID-19 work group for ACIP. I represent AAP on that work group and have since the beginning of the pandemic. And what I can tell you is that we've been following the data all along to see, who should be vaccinated against COVID-19, reevaluating all the time. Do we need to keep doing this in kids? And I think a lot of your listeners are probably aware that a lot of other countries are not currently vaccinating kids against COVID-19. And the reasons for that are somewhat complex, but one thing I can say is that vaccination recommendations really, really vary a lot across the world. There are vaccines that are given in other countries that we don't give here. We give certain things here that are not given in other countries. And what I can tell you about COVID-19 in kids and the data that we're looking at is there are very compelling reasons to continue vaccinating kids against COVID-19. The reasoning is that if you actually look at the burden of disease for COVID compared to a lot of the other respiratory things, a lot of the other vaccine preventable diseases that we routinely vaccinate for, the burden of disease is actually still higher in many cases from COVID-19 compared to a lot of these other vaccine preventable diseases, even before we started vaccinating for them. And that's true for both hospitalizations as well as deaths. So unfortunately, we're still seeing quite a few pediatric deaths from COVID-19, and those are almost all essentially entirely preventable with vaccination. And those numbers are actually either in line with, for example, influenza or higher than influenza, depending on the data source you look at. So, and that's not to downplay the need for influenza vaccination. We'll talk more about that. But the bottom line is, the data are still very compelling that we should be vaccinating kids.
Speaking of the flu, we obviously can't talk about fall viruses without mentioning it. It's something I actually got 6 weeks postpartum and do not recommend experiencing. We won't hold you to this, Sean, but how effective do we expect the flu shot to be this year?
Yeah, it varies year to year. No crystal ball. I mean, David gave me some nice compliments about reading tea leaves, but there's no magic here. It's just that we know from prior seasons what we can expect. And I think I can tell you that we are mostly getting back to seasonal circulation of viruses. COVID is still sort of settling in there in terms of what we're going to see. But in terms of influenza and effectiveness with the vaccine, most years we see somewhere between about 40 and 60% effectiveness in kids. And it also depends on the outcome you're looking at, whether you're talking about symptomatic infection or hospitalization. ICU admission, it tends to be most effective, for example, against ICU admission most years. So somewhere between 40 and 60% are probably the numbers we're going to see. Some of that depends on which strain becomes predominant, whether it's H1N1, H3N2, sometimes B is predominant, but we haven't seen that in a number of years. So it'll depend a little bit. The vaccine tends to be more effective against the H1N1 years than it does against the H3N2 years. But in either case, the influenza vaccination, even in years where it's not so effective, it still prevents tens of thousands of hospitalizations and thousands of deaths in the U.S. every year.
Do you recommend getting it early in the flu season or waiting because of concerns for waning immunity from the time you get the shot?
Yeah, good question. In adults, particularly older adults, there's reasonable evidence that there is some waning immunity, and there's a little bit of evidence for that in kids. The recommendation, though, is not to wait. And some say, well, what if we got it in August? Should we give it? And I think for August, I'd say certainly for those kids who are going to need 2 doses, sure, start it. If you have families who you think, they come back every year for a flu shot, sure, it might be fine to have them wait till September or early October, something like that. But in general, we don't recommend waiting because the benefit of getting the vaccines in the arms outweighs the potential for that waning immunity and less effectiveness kind of late in the season. One thing I'll add to that is that we know that in a lot of cases, if you wait, the people don't end up coming back in. And so you'd much rather have somebody get a vaccine and perhaps have a little bit of waning immunity than not getting the vaccine at all.
And as a pediatric hospitalist, I always get a little bit nervous around this time of year. Should I be? Sean, what infections keep you awake in this 2024-25 respiratory viral season?
Yeah. Again, I'm optimistic about RSV. We are still going to see RSV for sure. Nirsevimab and then the maternal vaccine seem to be, depending on the how far out you are from vaccination, somewhere between 80 and 90% effective at preventing hospitalization. So really, really high. But we're still going to see some. The other thing I'll mention about prevention of RSV is that these are preventing severe lower respiratory tract diseases, both products. They won't necessarily protect just against infection. So you're still going to see RSV in the office for sure. And there will still be some hospitalizations, even if we have extraordinarily high uptake. Flu is always a big concern. Every year, thousands of hospitalizations in kids, unfortunately, usually a few hundred deaths as well. And so flu is always a biggie. And then COVID, like I said, we're still seeing cases of COVID and hospitalizations in kids. I was on service last week and we had a couple kids in with MISC. So we're still seeing that a bit. And so, yeah, COVID is going to be there. And then, there are all the other ones that, we may see. We're in a year where we may be seeing a fair bit of enterovirus, that circulates every year, hospitalizing some kids. And then there's always the adenoviruses and other HMPV, other respiratory viruses that we see. Another thing that's potentially keeping me up at night, David, is pertussis. There are outbreaks around the country. We're seeing a big uptick in pertussis. It's returned at least to pre-pandemic levels and may go even higher from here. So that's a real priority. Just a reminder to your listeners, the only way to really prevent it in the young infants is to, one, make sure everyone around that infant, older siblings, parents, et cetera, are vaccinated, but particularly the pregnant person getting vaccinated in that 24 to 36 week window is really effective at preventing severe disease in infants. So that's one that I think we need to be thinking about going into this winter as well, because I expect we may see even more pertussis in the coming months. And then finally, measles. So we have been concerned about measles coming out of the pandemic for quite some time, and we're seeing more cases this year than we have since pre-pandemic times. And remember, in 2019, most cases since 1992. If anything, we are in a worse place now for measles than we were then. And so I would encourage your listeners to be thinking about measles in your communities, particularly if it's already there, thinking about it in anybody even that presents with a fever who's unvaccinated. And then if it's not there, when you are seeing fever and rash, start to remember, oh yeah, there may be some measles circulating.
Sean, any last takeaways as pediatricians enter one of their busiest seasons? And if you could make the message go viral, we'd appreciate that.
I don't know how good I am at making things go viral. I think we're in a really good place, I think, in terms of the vaccines that we have available. The problem is we do have this problem of increasing hesitancy, and the routine vaccines we're still doing pretty darn well. I think we're north of 90% for most of our childhood vaccines, but we've got a long way to go with things like influenza and COVID. And that's the really tough one here, I think, is that many pediatricians they're still not sort of recognizing that COVID-19 is still a problem in kids. One of the issues, I think, when you look at where we are with COVID-19 vaccine uptake, it's really, really low in kids. But when you actually look at what parents would be willing to do, when you look at surveys, a lot of them say that they would get COVID vaccine. It's roughly, depending on the survey you look at, 30 to 35% who would say that they definitely wouldn't get it. So the difference between how many parents say they'd be willing to get it if their pediatrician recommended it and those that actually do, it's a really big difference. So I think it's on us to really try and bridge that gap between how few kids are currently getting the COVID vaccine and how many potentially could.
Well, Dr. Sean O'Leary, I hope we're going to see that gap narrow as we go forward this year. And thank you so much for joining us today.
Always happy to be here.
For more resources on navigating this viral season, visit our website at aap.org/podcast.
Coming up, we'll look at managing sickle cell disease within the general pediatric practice.
One thing I miss since pivoting to hospital medicine is the continuity of care I enjoyed as an outpatient pediatrician.
I can imagine. I get to watch tiny babies become big ones, and I'm so grateful for the relationships I can build within a few months in the hospital. But being able to follow kids for years, that's cool and a really special part of pediatrics.
I know. Now, there are some kids I do get to know, unfortunately, because I get to know them over repeated hospital admissions. I have a small handful of children and adolescents, for example, with sickle cell disease, whom I've grown close to.
That just points to how much work we have to do in managing this chronic illness. Let's take a moment on the podcast to review a recent clinical report on sickle cell management.
I know a good person to help us with that, Dr. Zora Rogers. Dr. Rogers is a professor emeritus of pediatrics in the Division of Pediatric Hematology Oncology at UT Southwestern Medical Center. She's the immediate past chair of the AAP section on hematology and oncology and an author on the new clinical report, Health Supervision for Children and Adolescents with Sickle Cell Disease. Dr. Rogers, welcome.
Hello.
So, I mentioned getting to know families with sickle cell disease because of repeated hospital admissions. What is the pathophysiology of this chronic illness?
Despite the fact that this is probably one of the longest known genetic diseases, we're still learning about the pathophysiology. It has to do with the stickiness of the sickled cells everyone learned about in medical school. These sickled cells stick together and form different shapes, rafts, sometimes twisted polymers inside the blood vessels, blocking blood vessels. And as you might expect, what goes on beyond the blockage is ischemia. I mean, pins and needles when you sit on your foot too long. But imagine that pain going on and on and on, unpredictable, any part of your body, anytime. And it's not just an arm or a leg. It affects the spleen in young childhood. It affects the lungs, the eyes, the brain, pick an organ system. And it's affected by these blockages in the bloodstream. And they're not just a plumbing problem. It is a metabolic syndrome in which the body is using a lot of extra energy to make these red cells that aren't right. Meaning the child is spending extra energy, they don't grow well, to cause problems in all organ systems, including the brain.
You mentioned this is genetic. What is the inheritance pattern of this illness, and is there genetic testing for it?
A person with sickle cell disease has inherited, in most cases, there are some exceptions, as in everything in medicine, has inherited from each parent a gene that doesn't fold right in the hemoglobin molecule. Most commonly, the Sickle mutation, a single amino acid substitution in one position on the beta chain means that that chain doesn't fold right, leading to what we talked about before. They can also inherit a C mutation, a different mutation, not quite as severe. But if you inherit no normal hemoglobin genes, you have a form of sickle cell disease. The most common and most severe is sickle cell anemia. You can also inherit an S gene with a thalassemia trait or a variety of other mutant hemoglobins, all leading to a pathophysiologically not normal state. Genetically, these can be tested for at birth, not necessarily the thalassemia, that you have thalassemia trait, but what you will see is that you don't make any normal or reduced amounts of hemoglobin A. So newborn screening, seen in every state in the United States, finally, of all children recommended to have this, you can diagnose the disease at birth. It's diagnosed by what used to be called a hemoglobin electrophoresis. Now we call it usually a hemoglobinopathy evaluation because it's not done by the old technology of an electrophoresis. But that test should be done on every child in the United States at birth, is done on most children in all 50 states.
Dr. Rogers, sickle cell can affect so many different organ systems. Can you just run through the main acute complications that might land these children in the hospital?
I'll start and end with pain. Pain anywhere in the body with no obvious cause, or pain made worse from any obvious cause. So if you stub your toe and you don't really have experience of pain, you'll get over it. But if you stub your toe and you have sickle cell disease, you're going to say, oh, that's the start of a crisis. So pain anywhere. Second, hemoglobin. These kids run around with a baseline hemoglobin far below normal. So it's important to know what normal is, but also to remember that for a hematologist at least, and for children with sickle cell disease, a CBC is a seventh vital sign. Third, a physical exam focusing on the things that go wrong, and that is, has the spleen enlarged? Because if the spleen is bigger than baseline, that hemoglobin is going to be lower, and you have hypovolemia on your hands to address. Acute chest syndrome, if there is not a clear chest or a history of cough or a history of fever, you need to decide if a chest x-ray is needed. And you need not to give the extra fluids because that will simply flood and make more pneumonia or acute chest and make it much worse. Young men starting at, well, the youngest I've ever seen is 6 months. Young men with sickle cell disease develop priapism, and painful unwanted erection of the penis not associated with any thoughts or actions, simply physiology. That, if not treated aggressively and appropriately, can lead to impotence. And I'm talking in early childhood that is lifelong. So it can affect everything in any pattern, at any time, and in any way the disease chooses to do, because it's a random event.
So, is there monitoring or screening for sickle cell disease that general pediatricians should be doing regularly to help these children before they get hospitalized?
Well, that's sort of the intent of the health supervision for children and adolescents with sickle cell disease, is to provide support to the general pediatric provider in their practice for what needs to be done and to really advocate for these children that co-management between the general pediatrician and a specialist team or hematologist is really vital to providing optimum health outcomes. The report, there's a table 2 that talks about what to do at every pediatric well child visit by age. But the big things that we really want pediatricians to understand is that they have a role. Number 1, make sure that newborn screening is reclaimed from the state. It takes a bit of effort sometimes, but you can do it. Take that newborn screening and make sure it's in the hands of the patient and the family. You're saying, but a baby, they don't really want to know. Well, tell the parents so the parents can be aware of it if there's a subsequent sibling to be conceived, of the genetic risk in their family. And they need to know not just, oh, your baby has disease, but the fact that this means you have to have trait. Or this baby has trait. So do you and your partner know your trait status so you know if you're at risk for disease? These aren't guiding counseling. This is simply education, and knowledge is power. So newborn screening to the infant and the family, and then at school age, making sure that if they have sickle cell disease, there is a school plan in place, including a 504 if appropriate. Then at pre-adolescent visits, that sex talk you have to have with most kids. It includes the fact, yes, you have sickle cell trait or disease, but how's the pediatrician to know that? Got to have that newborn screening. And then every visit in an adolescent and transition visit to adulthood, you remind them of the presence of disease or trait, not to tell them what to do, but to tell them that they have it so they are not unaware. Knowledge is power. So that's the minimum I think a pediatrician can do. The maximum, the report outlines it, but it is making sure that they have access to a specialist team if it's at all available. And that frequently involves insurance or public assistance program advocacy. It's not enough to refer them to the specialist 200 miles away, as we have in Texas. It's finding a way to make a plan to get them there. And those plans exist even through the state Medicaid programs, but you have to advocate for your patient. Then with the hematologist or the specialist team, make a plan who's going to do what. Who's going to provide the penicillin prescription if that's appropriate up till age 5? Who's going to give the vaccines? Ideally, that's done in the pediatrician's office. Routine vaccines, but it's the child with sickle cell disease of any kind for whom the pneumococcal and other vaccines are critical. It's okay to be a little behind sometimes. We all see pediatricians have to deal with realities in their patients, but it's the sickle cell kid who needs the reminder to come in at 2, 4, 6, 12, 18, 24 months and get those vaccines. Those are the critical things for pediatricians, and I think that's in everybody's wheelhouse. Other things, and this is where for pediatricians in an urban setting where the specialist team is a bus ride away, not as critical. But for providers in rural communities, make a plan for where the child should be hospitalized. Where should that child present when they are sick? And then go over the teaching, which is really, really basic. If the child gets a fever, pick a number, again, co-management to decide what the number is, but be consistent. My practice, we used 101.5. You hit 101.5, you need to have your child in the hospital emergency room for evaluation within 2 hours. So there's a lot of planning bits there. Then as the provider in a rural community, you need to make sure that the provider in the emergency room has some vague clue what to do. And that is draw a blood culture, give a dose of an antibiotic appropriate for the child's weight that will cover pneumococcus, and then do whatever else seems to be appropriate. If it's COVID, if it's a runny nose, if it's an ear infection, none of that matters. A child with sickle cell disease and a fever of a number over 100.5 to 101.5, depending on your center, needs that intervention. But vaccines, fever plan, and then pain plan. So developing a way so that the child doesn't become used to feeling bad and hurting is critical. And that requires the use of real analgesics, not waving a dose of Tylenol over their heads. It means if you or I have serious pain, we expect treatment with a nonsteroidal plus an opioid type medication. So that means working with your hematology expert, because that's where the comfort comes in, I think, for the generalist, deciding what pain medicine is appropriate for the child at what age and weight. So not just advising on Tylenol for fever. And if you hear me saying acetaminophen for fever, the reason I'm saying it that way is that is a no-no. You don't give acetaminophen for fever to a child with sickle cell disease. They go to the emergency room, get evaluated, and then one hopes the discharge medicines will match what you've planned in advance.
And then in terms of vaccination, are general pediatricians just following the routine schedule?
You're following the routine schedule, but the routine schedule for children who have asplenia. In the Red Book, this is a special cutout page. We reference it in the report. It changes, and it will change more in the near future. So you're looking at specifically pneumococcus, meningococcus, and basically making sure that these kids keep up with everything they need to keep up with. And that is a job and a half for the general pediatrician.
So I want to pivot a little bit to treatment. I think that most of us are at least familiar with penicillin and hydroxyurea, but what are the basics that we should know?
The basics are you're more likely to form those log-jammed blood vessels, intercellular aggregates of cells, if you are dehydrated, stressed, have other problems, things that we talk about as general health. Drink enough water, get enough sleep, watch your stress levels around school. And the one that gets a lot of my patients is when they become teenagers and are going to college, they don't know how to take care of themselves. So on a general health level, just avoid the triggers if you possibly can. Other things that can be done, there are a list of medications in the report that are emerging as possible adjuncts to care. But the fact remains, every child with sickle cell anemia and S beta zero thalassemia needs to be offered penicillin until we figure out where we are with pneumococcal vaccines. They should be offered hydroxyurea at 9 months of age, but many families aren't willing to take it. So again, an opportunity for the general pediatrician is to understand why the families are saying no and to offer it again. It's not that they have to be on it. It's that they should be offered it.
Zora, so much of pediatrics is moving toward an increase in mental health support and training. So what psychological and social supports do children affected by sickle cell disease need as they grow?
Number one is an understanding that what they're experiencing is normal. And rather than causing it disease, it's if you have sickle cell disease, these are the things that you might experience. Probably the most obvious for patients with SS and S beta zero is growth delay. If you have a hemoglobin of 6, you're not going to grow as well as a child with a hemoglobin of 12. And these children do grow more slowly. They tend to enter puberty later, so that's a big psychosocial stressor. When you have a 14-year-old who looks like a 10-year-old and weighs what a 9-year-old does. You have to normalize it so you're growing well for you. You have to be proactive that, yes, they're going to be smaller, but eventually they will catch up. You need to be aware that if a child is experiencing pain all the time, they're not going to develop normally. They're not going to want to do the things that lead to normal development. So try to treat that pain aggressively, but for the shortest period possible. And if hospitalization occurs, make sure that they don't lose the academics of what they missed in school, but they also didn't miss the bonding experiences with their friends, and look for activities they can participate in that socialize them with their peers, but that won't aggressively make their disease worse. So I'm not a native Texan. I actively discourage playing football for all my patients. Boys, girls, I don't really care. But my partner is was a good old Texas boy, and he didn't say no. He was more strategic, and he said, well, maybe you should be the kicker. Marching band's a big thing here. And instead of being drumline or playing a wind instrument, maybe you ought to find something else that you can do with the band that won't put you on the field in 110-degree heat all the time. Find the things that the kids can do. You'll know your own environment. Maybe it's playing soccer. Maybe it's playing indoor basketball. Think about the differences in those two body stressors. Make sure the children are normal. Treat them as normal, as a normal kid with sickle cell disease. They're not their disease.
Well, Zora, I am so grateful to have this comprehensive report, and I know we could spend hours talking about it. But before our listeners read it for themselves, do you have a last takeaway to share?
I think the most important thing is this is not a tertiary care level of evidence referenced report. We started with that. But we decided we wanted to provide practical guidance for the general pediatric practitioner with a child with sickle cell disease in their practice, or the general pediatrician who says, I don't want that. And we want them to feel supported and encourage them to include these children in their practice. Don't just take the siblings who don't have disease. Take everybody and treat them the same. And the report basically is something you could stick into the child's medical chart, at least the table, and just at each age follow what you're supposed to be doing so you know that has it happened or not. So it's designed as a supportive document, and I think we've actually hit the right note with a lot of input from the sections and committees in the AAP and exterior reviewers. And I think a general pediatrician can get something out of it.
I think they definitely will. Dr. Zora Rogers, thank you so much for talking with us today.
My pleasure.
To read Health Supervision for Children and Adolescents with Sickle Cell Disease, a clinical report, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
You know, I'm saying because the absolutely stifling heat of southeastern North Carolina is finally breaking. And you know I will run and bike in almost any weather, but right now it's fun again. So Christy and I are going out there, and oh my gosh, when you don't have to cut the air with a knife, it just feels like you're flying. So I am enjoying that very, very much.
Well, you know, David, that I will never run. So I'm going to make my Say no matter the weather. I'll make my Say about reading instead, which is that my first grader has wanted to now read in bed by herself before bedtime, which is like great. But I'm very strict about bedtime too. So, but I was so proud of her because she's like really starting to get into books, and it's kind of hard to say no when she wants to read in bed.
Yeah, no, I mean, you're like, sure, absolutely.
I want to foster this love.
Absolutely. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at oral and dental aspects of child abuse and neglect.
We'll talk to the authors of a new clinical report, Drs. Laura Spiller and Anu Tate. I'm Dr. David Hill.
And I'm Dr. Joanna Pargabalinki. Thanks for listening.